Hear the latest reporting and analysis on the big stories of the day on the Daybreak Insider podcast. It's top-notch reporting from SRN News, along with the sharpest insight from Hugh Hewitt, Mike Gallagher, Dennis Prager, Sebastian Gorka, and the voices of townhall.com. The Daybreak Insider podcast. It's your first look at today's top stories. Available at Apple Podcasts, Spotify, Google, and at SalemPodcastNetwork.com.
Tired of dealing with vein disease? Have your symptoms gotten worse?
Oh, these spider veins are ugly.
My legs and ankles are always swollen.
My legs are tired of standing all day.
While some symptoms can be managed by lifestyle changes, other factors are out of your control. Get help from the experts at Vein Clinics of Hawaii. To learn more about your treatment options, call 427-5565 or visit veinclinicsofhawaii.com.
Aloha, Hawaii! It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juleff of the Vein Clinics of Hawaii.
Well, hello there, and thank you so much for electing time to spend some time with us. We know that a lot of things are pulling and pushing at you these days, and it's good that you can sit back and relax and learn a little something. We're just reviewing this, and Dr. Juleff and I have now, we need to bust open a bottle of champagne, and this is program number 150.
That's pretty good.
That is pretty good.
Very good.
Yeah, and I'm still learning stuff. And not only, by the way, gang, I get really side benefits and bonuses out of this because not only do I host a show here with Dr. Juleff, but I'm also a patient, and I'm learning how to be a patient. And it's funny because today we're going to do a case study, and I was looking through the materials that you sent me, Doc, and a lot of what this guy is kind of reflection of me. So I'm very interested to find out how we're going to do. We're talking about deep venous thrombosis and travel, and we know that sometimes those things go together not too well. And so we actually have a case today, and that's what I love talking about. Let's get going.
Yeah. It's apropos because, we're going to be seeing more and more people traveling back and forth, not only over here, but also people who have probably felt pretty stranded here in Hawaii and wanting to get back and see family and et cetera. There's going to be more travel. So one of the things that we like to talk about are the risks of traveling, and one of those is this thing we call DVT, or deep venous thrombosis. But so we had a patient come in recently, and he was 71-year-old male. He presented to the office. His chief complaint was pain in the right calf that had been there for the past week, and it was not resolving. Mm-hmm. So our antenna went up, and we started asking questions. Well, we always ask a complete history of their medical history. He had a history of high blood pressure. Mm-hmm. He had suffered 2 heart attacks in the remote past. However, his heart status was pretty stable. And he also took a cholesterol medication. So, kind of a routine kind of history for somebody of that age. Mm-hmm. He also had a pacemaker, so that may have played a role.
Yeah, he's been around the block a few times.
Yeah,
right? Yeah.
He had been admitted to the hospital on 2 occasions in the past for congestive heart failure. So he had two heart attacks.
2 heart attacks, yeah.
And then in addition to that, presumably because of the impact the heart attacks had on his heart, he had some problems with cardiac function and was admitted, but was in fairly good overall health, at least at this time, and he was traveling. Mm-hmm. So the most recent heart attack had been several years prior to that. So again, he had fully recovered from that. He had not had any major surgery otherwise in the past. He had the pacemaker, but no major surgery. He was retired, but had remained relatively active. So again, the 71-year-old guy had a couple medical problems, but was otherwise pretty functional and active. He had not been treated, as far as his vein history went, he had not been treated for vein disease in the past. Now, when people come in, we always ask about their family history. He remembered that his mother had varicose veins. And he remembered that from when he was a kid, but she had never had them treated before, which, for that
back in the days too, that
for that generation, not surprising that she did not have treatment. His father's side of the family was negative for vein disease, so he did have a positive family history through his mother. He did not have varicose veins when he presented, and his report was that he had never noted varicose veins or dilated veins on the surface of his legs. We typically ask about swelling, and he stated that he did have periodic swelling of both legs, especially on long plane rides. And on occasion when he had been on his feet for many hours throughout the day. So, swelling is one of those things that it can be caused by a number of different things. This guy had a heart attack and had congestive heart failure in the past, and heart disease is one of those things that can create chronic swelling. But also vein disease is one of those things that can also cause chronic swelling. So. Of course, we're always, interested to hear about the details of that. He had never worn compression stockings, although he had been told in the past that it would be beneficial for him. Although he said that he didn't really remember, what exactly the reason for that was. So,
because he's probably like me. I did everything I could years ago to avoid it. It's too late now. I wear them it's like brushing my teeth. On go the socks.
Yeah. Well, he was probably like most people. Most people don't really cherish the idea of wearing compression stockings, but they can be very, very beneficial for sure. So we asked him about recent travel, and the answer to that was yes. He had traveled to the mainland and had returned about a week prior to his coming to the office. Did the pain start on the flight? He said no, it did not. It did not start on the flight, but it did. He did notice it, or he didn't notice it until he got home. After he was off the plane and he was home for, I think later that day, he said he started to note this, pain within the calf. So he described it as tight, crampy feeling in the left calf muscle that would not go away. He tried massaging it, tried walking, but whatever he did, he didn't. It had no impact on it. So initially, he didn't think too much of it, but the muscle was a little tender to touch. When he was massaging, the muscle, he noticed that he had some tenderness. And it persisted, however, over the subsequent several days. He seemed he felt like it got a little better, so he was, that helped him ignore it even further. But after that, it started to get worse. So he had this plane ride. After he got home from the plane ride, he noticed the left muscle cramping in the calf muscle. Was moderate to begin with. Over the next several days, started to improve, but then it started to get worse.
Interesting to me as you explain this. In many other times we talked about the same thing. He had lucky this long period of time. A lot of people are not that lucky. Something happens, it's like right away. Right after they get off the plane, or in the next day or two or three at the most.
Yeah. Right. I mean, some people with if they develop a blood clot, it can be fatal very quickly, for sure. So, so he was lucky. He was lucky in a sense. I mean, he was lucky in that he had this progression of symptoms, because that's what then finally got him to evaluation.
I'm sick and tired of feeling sick and tired.
Yeah. So in addition to the discomfort in worsening, he also had additional swelling. And again, so those, this persistent pain that was now worsening and the swelling, occurring then, kind of pushed him to come in. So he came in and we kind of defined, this story a little more. We did a physical examination. He had good pulses in his feet. So we didn't feel like it was an arterial problem. Skin was normal looking. And again, all of those things that we would presume if it was not necessarily an arterial kind of problem. Mild to moderate swelling of the calf, ankle, and foot of that left leg. The calf muscle was a little tender when we palpated it. He had what's called a positive Homan sign. Now, what is that? A positive Homan sign is pain in the calf muscle when you lift, if your foot's on the floor and you lift the front of your foot. We call that dorsiflexion. So if you flex your foot up, do you get pain in the calf muscle? If the answer is yes, then we call that a positive Homan sign.
Every time I've traveled since we met and since you talked to me about this, I use that.
Yeah.
A lot.
Right.
Yeah.
Moving the foot,
that calf muscle up and down.
Yeah. And basically that's what you're doing when you're flexing the foot. You're kind of stimulating the muscles in your calf to work. So anyway, positive Homan sign is something that we look for in DVT. It's kind of one of those classic signs of deep venous thrombosis. With that, in his exam and the story, it was all kind of pointing in our minds that this guy probably had developed DVT on the plane. So we did a duplex ultrasound and immediately found a DVT. And it was in the thigh area and in the vein that runs behind the knee. So we call that femoral popliteal. Femoral vein is the large, deep vein that runs through the thigh area. The popliteal vein is the continuation of that vein, but as it goes behind the knee. And we would, that would be a moderately extensive DVT, if we see that from basically it's a DVT in the deep vein from the groin to the knee. So, fairly extensive. So we started him on a blood thinner. His symptoms resolved fairly completely over the next several days. We put him in compression stockings, which is also an important part of the treatment of DVT. Not only should we put these people on blood thinners, but they also benefit from compression. Yeah. And some people, you might intuitively, you might think, gee, you put on a compression stocking and it's going to, squeeze the blood clot out of the leg and
I
make it go somewhere.
That, and it's actually the opposite. It's amazing.
Yeah. So, we want to do everything that we can to benefit flow through the veins, because that's going to limit propagation of that blood clot along with the blood thinner. And again, like we've talked about before in the past, the blood thinner is not going to dissolve the clot. It's just going to stop the clot from getting bigger, and and it helps the body kind of start to process that clot. It stabilizes the clot. It's going to make it less likely for that blood clot to break off and go through the bloodstream and become a clot that goes to the lungs, something that we call pulmonary embolism, which is not good. And can be sometimes fatal. So after the swelling resolved, so now we're several weeks, beyond his presentation. He's several weeks into his treatment with blood thinners, and the swelling, the symptoms have resolved. The swelling has gone down, and at that point, then we did another ultrasound to look at his venous system from a functional standpoint, because the question there is not only keeping track of the blood clot. We want to, do serial ultrasounds to make sure that it's not, for whatever reason, getting bigger or moving, et cetera. We want to confirm that. But we also want to know if this guy has venous disease, because he may have venous disease. We talked to him a little bit while he was in the hospital, and after we spoke to him a little more specifically about some of the symptoms that can be consistent with chronic venous insufficiency or venous reflux. He had some of those symptoms, looking back over the years. And also people with venous insufficiency, they're at a higher risk of developing a DVT. So, in this guy, probably, he was a long plane ride, so he was immobilized for a certain period of time, and he had some heart disease, and he had venous insufficiency. So he had a number of things that would put him at a little higher risk of developing DVT. But from our standpoint, we also want to find out if he has venous insufficiency that should be treated, and unfortunately this was his kind of presenting complaint, or his presenting scenario, his presenting situation was this DVT that then got him to us, and full evaluation led us to find out that he had venous insufficiency, and we ultimately treated him after he was, again, fully treated for the DVT. We sort of eliminated that from the overall picture, and then treated him for his venous insufficiency.
And one of the things I've noticed about this particular case is it's a circuitous route it took to find out that he had other things that were down the road going to need some treating.
Yeah.
Because in the very beginning, when you first started to describe him, he sounded like, all right, he's got some issues, but he's 71, but he's still in pretty good shape, and he can still move around a fair bit.
Sure.
So he probably was absorbing some of those symptoms without even thinking about it.
Yeah, he had, like many people, he had had symptoms that he was writing off, He was saying,
getting old. That's right.
I'm getting old.
I got to lose 20 pounds or else,
Yeah, so... So another question in his story is, what's the importance behind the waxing and waning of his symptoms?
Yeah.
And this is something that would go to the concept of, if you're having symptoms and you're not sure why you're having them, you probably need to have them looked into.
I would say. And by the way, one of the things that we talked about earlier, and this happens at veinclinicsofhawaii.com, I'll throw that in there all the time, is that because of technology and all of the things that we need to know, that you go through a rather rigorous application of a little iPad and cover a lot of these things. And that's isn't that where you get a lot of guidance from the specific things you should look at about this patient or that patient, because of all of the things you see that by process of elimination, you can sort of zero in on what his or her condition might be.
Absolutely. Because, a lot of those things are pointing us in the direction of, what is this patient at risk for?
What is it? Yeah.
And so that helps us kind of narrow things down. But, in him, probably what happened was that he developed a DVT on the plane. When he got home, started having symptoms from that. And it probably was not anywhere near as extensive as it was when he ultimately then came in.
Yeah, that's what I'm guessing. Yeah.
Because, his symptoms started to resolve, and so his body was starting to process the initial size of the clot that he, first had. And then all of a sudden, then his symptoms start to escalate. So probably that clot was propagating. It was getting bigger.
Getting bigger, sure.
And, so had he come in initially when he started having symptoms, and we would have been able to do an ultrasound at that point, maybe the clot would have been nowhere near as extensive as it was, and so those ultimate repercussions that we'll talk about here in a minute, would be much less likely.
Gotcha.
Because the bigger the blood clot, the more extensive the blood clot, the more likely it is to have permanent repercussions to that vein. So anyway, how common is DVT PE, and we kind of put those two things together: deep venous thrombosis with pulmonary embolism. But they are the leading cause of morbidity and or it is a leading cause of morbidity and mortality throughout the entire world.
Gee whiz. That's a lot of that's a lot of them.
Yeah, 10 million cases are reported yearly throughout the entire world, and this is even the numbers are probably substantially underestimated because of all of those situations that we don't know about. Because people die suddenly all the time, and we don't know exactly what it was due to. So
you have mentioned, Doc, in previous shows that many times what the medical examiner or whoever decided the cause of death was a heart attack. And then no autopsy is needed. The guy's dead.
Right.
And so a lot of these things are, I'm sure, woefully underreported.
I think you're right, especially heart. I mean, I think when people die suddenly, I think the first thing that most people jump to is
oh, come on, he was 88. It's time to go.
Exactly. So DVT, PE are very underdiagnosed, and so the real incidence and all that is probably something that we don't know exactly. But DVT is the single most common cause for hospital-acquired mortality. Now, what do we mean by that? Well, what we mean is, people going to the hospital, and just going to the hospital is a risky business. You know
what? I'm glad you said that, because a lot of our listeners know that I spent some time in the hospital, and I did notice a lot of things, and one of them was, you can get a little bed sore, you can get a little a little bit of that, a lot of things, because you're just not mobile. So the longer you stay in one of those facilities, the more you're you think, I'll just go back to normal, get on the bike and go riding.
No.
Sometimes got to walk way before you run again.
And you're right. The longer that you're in the hospital, the more likely or the higher the risk is for everything. But, one of those things that happens when people go in the hospital is that we throw them into bed. And we stay there.
You need to stay. You're bedridden.
Don't get up unless you tell us.
Right.
But
interestingly enough, and I know this happens in a lot of rest homes, that the real good ones and retirement homes is that when people are bedridden, every couple of hours somebody's there to help them to move them around a little bit, so they don't develop that problem that this guy could have had.
Right. And the other thing is, over recent years, and by that I mean, the last 20 years, I think that the medical community at large has gained so much more understanding about DVT in the hospital, because the incidence of DVT before we were a lot more proactive the way we are now, because people go into the hospital and virtually everybody gets put on some sort of DVT prophylaxis, some kind of medication, usually heparin or Lovenox, something like that. And
are those blood thinners?
Yeah, those are blood thinners, and that has become protocol. Now it hasn't always been like that. And again, I don't know exactly the number of years, but 20, 25 years ago, we weren't doing that, and still we still have a hard time, kind of accomplishing that at 100%, degree.
Well, remember once when we spoke of this a long time ago, and it was like, the man or the lady, the elderly man or lady that breaks their hip and goes to the hospital.
Yeah.
And then they get pneumonia and die.
Right.
And it's like, now you connect the dots that going to the hospital was not a good experience.
Yeah. That's another prime example of what we would call a hospital-acquired mortality.
Yeah.
Somebody who goes into the hospital, they develop pneumonia or whatever, which they probably wouldn't have had they not been immobilized and put into that setting. So again, DVT is a very common cause for hospital-acquired mortality. DVT in a significant number of people will lead to this thing that we call post-thrombotic syndrome. and that's something that has to do with the fact that, the blood clot has a negative effect on the function of the deep vein. And that as that deep vein then loses its function, we can develop reflux or venous insufficiency in that deep vein. And over a long period of time, it's going to have the negative repercussions of, developing chronic swelling, discoloration of the skin of the lower leg, development of abnormal skin, thickening and fibrotic skin that then becomes very friable and is prone to skin breakdown and chronic ulceration. So, not only is there, with respect to the cost of somebody developing a DVT, not only is there that immediate cost of hospitalization and drug therapy and all that sort of stuff, but those negative repercussions may go on for years, and that patient, 15 years from now may need further treatment for venous stasis, ulceration, and all of that stuff. So. Over $27 million is spent yearly on the treatment of DVT-PE in this country. A lot of money.
Yeah, and by the way, gang, it's gloomy. I mean, you need to wake up and realize how important this is, and that's why I think maybe in a way, Doc, that's why you do see a lot of medicines being advertised on television these days, particularly dealing with that because they know it's a wide open category that people need attention.
Yeah. So, and not only is there a cost of treatment, but there's also the economic cost of people not being able to work. And so there's an overall negative repercussion with respect to the general economy. So what are the risk factors? There are innate risk factors, and those have to do with age. Being male, unfortunately, I have to tell you that, Mike. Men are more likely to develop DVT than women. You know what?
That's a fair trade-off because the poor ladies, they got so many other things that they get that we don't.
Sure.
So I'll take a shot at that. I don't want to experience pregnancy ever.
Yeah. Family history. We've talked before about genetic thrombophilias. That is, you may have a genetic trait. That is going to make you more susceptible to, blood clot formation. So those are innate things. Those are things that you can't change. We can't change our genetics. So we can't change our family history. And then there are acquired things. For instance, cancer. People with cancer have a higher risk or a higher propensity to develop DVT. Having had a prior DVT, once you've
had one, now you're theoretically, why aren't you going to get some more?
Yeah, right. Once you've had a DVT, your risk of DVT is higher than it was before you had one. Medical comorbidities, and by that we mean, heart disease and lung disease and all that sort of stuff. Varicose veins. If you have varicose veins, you have a higher incidence of developing a DVT. And that goes along with, the fact that people with venous insufficiency in general, with or without varicose veins, but, particularly if they have varicose veins, they have a 5 times increased risk or likelihood of developing a DVT over the course of their lifetime. Recent pregnancy. Recent surgery, of course, especially pelvic surgery, so GYN-related stuff, especially orthopedic surgery. The rate of DVT formation post-op from orthopedic procedures is very, very high, and that's why it's so very, very important for people undergoing orthopedic surgery to be on some sort of prophylaxis, again, to prevent them from developing a DVT post-op. Trauma, bone fractures, obesity, various medications like birth control pills. There's a number of medications that can make you more susceptible to developing a DVT. And those are all things that, we need to ask our doctors about, and have a a much better idea as to what, overall your risk might be. Do you have a family history of DVT? Well, if you have a family history of DVT and you're on a medication that you might put you in a little higher risk bracket, then those are things that you need to discuss with your doctor.
Interestingly enough, gang, you can do this at veinclinicsofhawaii.com as well. Veinclinicsofhawaii.com. A lot of this stuff is laid out. We do this program as a way of entertaining and informing you, but when it gets down to the brass tacks, a office visit is going to be something you want to think about. So please, when you get a chance, check out veinclinicsofhawaii.com.
So most of us, most medical communities have ways of assessing the likelihood or the risk of a person to develop DVT. For instance, in the United States, we use something called the Caprini risk assessment tool, and that's just a way that we can look at people and plug in their individual criteria and get an idea about the likelihood of them developing a DVT, especially post-op. Other countries use other systems. That's just the one that is the most utilized in this country. All of them consider immobility as being, part of their scoring system. So, you get a certain number of points if you're, for whatever reason. It all points
it that way, doesn't it? It really does. Everything.
Oh, yeah.
Whether
Absolutely.
you're in bed or in an airplane or in a bus or a car or whatever.
Yeah, whatever's causing the immobility. It increases your risk. So none of them, however, interestingly enough, add long-haul travel. And that's we're kind of talking about that specifically today, especially with the patient that we presented. None of them use long-haul travel, although obviously there is a connection between long travel situations, be it a plane, train, car, whatever, and the risk of developing DVT.
I get a kick out of that when we talk about it here in Hawaii, because a lot of people here just do a puddle jump. They're in a 20-minute flight. Some of these other flights you're going to talk us about, you're on the airplane for a long time.
You're right. The shorter the flight, the less the risk. Right. And when you're flying from one island to another, there's very, very little risk. However, if you're going to the mainland, or if you're going to Japan or Asia, that's a considerable flight,
I should say.
And, so the risk is going to go up. So now the longest flight that we have available to us these days is Singapore to Newark.
How long is that?
19-hour flight.
That's like what, 3 meals and 3 movies or something. That's a long flight. Oh boy,
I guess, at least 3 movies.
But remember when it used to say, "Feel free to walk around the cabin"? They don't say that.
You don't hear that anymore.
No. Oh boy.
Yeah, feel free to stay in your seat and don't bother us.
And don't remove that seatbelt under penalty.
So what is long haul? Long haul is considered anything greater than 6 hours. So, most flights are going to be pretty close to 6 or over, just going from here to the mainland. Depending on where in the mainland you're going, it could be, a couple hours more than that. I fly very often between Honolulu and Dallas-Fort Worth.
How long is that one?
That's about a 7.5 hour flight.
So 8 hours almost.
So that's well above 6 hours. So medium haul is 3 to 6. Short is less than 3. So in like we talked about, the risk goes up the longer that you're on a flight. In 2018, it was estimated that over the next 18 years, air passenger numbers would double. Many of these Asia Pacific, and therefore
just waking
very long
up to
flights.
travel and all that stuff, huh?
Yeah. So as far as the history goes, the first report of a DVT being associated with air travel was in 1954. Huh. And it was made by this guy named John Homans of Homans Sign fame, the one that we talked about before. It just so happened that a colleague of his was traveling from Boston to Caracas.
That's another long one, huh?
And which was about an 8-hour flight. and apparently he developed a DVT. So Homans, who was a physician and was obviously had an interest in vascular things, and he was the one again that created this Homan sign, which was when you flex the foot, you're going to get a pain in the calf if you have a DVT. So he kind of connected the two. Unfortunately, we don't have a lot of good studies that have been able to help us define exactly how important long haul travel is with respect to DVT formation. And many again, maybe subclinical. For instance, this guy, our patient, he may have, although he went in the opposite direction, he went in the direction of that clot getting worse.
Getting worse, yeah.
And so he was kind of forced to come in. But, let's say let's say that didn't progress. Let's say that, which may very well have happened. Let's say that he had developed kind of a limited clot to begin with that gave him those initial symptoms. And then his symptoms started to recede. So, what was going on there was that his body was starting to process that clot and probably starting to break it down. And we also develop what we refer to as collateral blood flow. So, when one avenue, when one vein is obstructed for whatever reason, blood starts to form. Blood starts to find other ways to get around that blocked area. It's kind of like getting off the highway. When there's a highway accident, things block up immediately, in a bad sort of fashion, but then cars start moving off to the side streets, and then traffic starts moving again. So same sort of thing. So his blood traffic started to move. And had he not had then that further progression or that secondary kind of progression, he may have just gotten better. He may have, his symptoms may have gone away, and that would have been the end of it. So, and that probably happens not infrequently. And so many of those patients, or those people we don't know about, so there's plenty probably of what we would refer to as subclinical DVT that occurs on long flights, and we don't know about them.
I would imagine that the science will be greatly enhanced later on, because now that, like you said, we're doing so much more of it, they can start to see patterns and start to think, well, we better rethink some of these things.
Yeah. And it would probably, it would certainly be interesting and beneficial for us to find, a way to kind of in a more scientific fashion, look at that, we just haven't done it yet. But we do know that it's related to the length of the flight. For instance, your relative risk of flights over 8 hours is 2.8. So the risk of you developing a blood clot is 2.8 times more
that's a lot.
than if you're on a flight that's less than 2.8 hours. So that much we know. And then it increases by 26% for each additional 2 hours.
I do know that, and I meant to ask you this on a different program, that there's some folks that travel a lot, but they're smart, and they'll fly. They go to New York. So what they'll do is they'll go to L.A., spend the night, and do something, and then the next day they'll do it again to break up that long flight. Right.
Which again, if you are aware of your risk and if you think that you might be higher risk, then that
maybe
is
especially
definitely
if you've had one,
definitely right, exactly. Yeah. So interestingly, that number is higher than for other forms of travel, even if there is immobilization involved. So there's got to be something about in a plane. Because we don't see the same thing. For instance, if people are traveling in a car or in a train or whatever, but. There is some conjecture as to what's going on inside a plane that may make it may make that scenario more likely to develop DVT. One idea is that there has something to do with the lack of or the diminished oxygen that our bodies are seeing, for a short period of time while we're up there. Immobility, obviously, that goes without saying. But the risks seem to be cumulative. The more you have, the higher your risk. Malignancy, pregnancy, obesity, all those things. So
I got a quick question, just out of curiosity. Do you think, there's a lot of guys that are truck drivers, and they especially nowadays, they're everybody's competing for length and speed and delivery. Some of these guys are driving 10, 12 hours or longer.
Mm-hmm. Right.
And they stop for fuel or for a sandwich or something, but basically, aren't they a candidate?
Oh, yeah. Absolutely. Absolutely. So another little interesting point about air travel is that there not only is your risk of DVT, occurring while you're on the flight and immobilized, but that risk goes on for some period of time after your flight. And some people think that it may be up to 6 weeks after you're on a long plane ride that you may be have this hypercoagulable state. That's continuing until, your body is doing whatever it needs to do to resolve it.
Doc, there's half the people that are out there listening are thinking, gee, the last time they talked about this is like, get on the plane, get to New York, have a DVT. And what you're explaining is that they take, like everything else, there's all kinds of factors that determine how long it's going to take to get worse or how long it's going to take to get better.
Yeah.
Amazing.
Right.
Yeah.
Right. So what do we do to reduce the likelihood of developing a blood clot on a flight? And, of course, number one is compression stockings.
Number one.
And this has been looked at.
Yep.
And the incidence of DVT decreased from 4.5% for those not wearing stockings during flight to 0.24%. So 4.5 to less than 1.
Yeah.
So that we know. I mean, that we know that intuitively, and there are studies out there that would indicate that also. So, and then another thing is maintaining good hydration. So we need to drink plenty of fluids. Those fluids should probably not include vodka.
Or 7 Diet Cokes on the way over, or whatever.
Yeah. So good hydration. And those, exercise too, walking the aisles periodically. And usually what I tell people when they ask me about it, gee, how often should I walk? I tell them about every hour. You should get up and, and especially if you are of an age and medical status such that your risk is high, even if you are on an overnight flight, it is going to be it's going to be better for you to get up, every hour or so and take a little walk.
One of our listeners, her name is Martha, and I see her every now and again, and she said, how come when she gets to the other end of a flight, her shoes won't go back on?
Yeah, right.
That's really common, isn't it?
Oh, yeah.
Especially us local people, we take our shoes off. Well, that didn't work out for me one time. I got to San Francisco from Honolulu, couldn't put them on. Mm-hmm. I'm walking through the airport like a dove with my shoes in my hand. So, but that does show you, right, inactivity. Yeah. Had she walked around a little bit, it wouldn't have been maybe as severe.
Yeah, it probably wouldn't have been, for sure. But also if, I ask about that just in general. That's kind of a general question that I ask for people who come in with a question of venous insufficiency, because that can be kind of one of the first signs of the whole concept of swelling. Do you, even though they're not maybe having swelling day to day in their usual, day to day life activities, but if their lower legs and feet swell when they're on a flight, then that probably puts them into a little higher category risk for venous insufficiency just in general.
I learned a lesson: don't buy shoes when you first get touched down somewhere.
So, and then the other thing is, if you can't walk or you don't want to walk the aisles, then you can do exercises in the chair. you moving your feet up and down, moving your your whole leg up and down. Anymore, most of these
walk in place.
Most of these airline magazines, usually in the back section, has a little article about
thank goodness.
that.
That's
and I think that is a good thing. It shows you the 2 or 3 exercises that you can do too. And basically, you just want to get your leg muscles working, especially your calf muscle. You want to invoke that calf muscle pump that we've talked about.
Big pump.
And when you contract your calf muscle, it's pushing blood through your veins, and that's what we want. So, one study that we looked at travelers treated with nothing and compared aspirin. Some were treated with nothing, some were treated with aspirin, and some were given a single dose of heparin, which is a blood thinner. So they compared, in this particular study, they compared those 3 groups of people. The heparin injection was much better than the other 2, as might be, pretty obvious.
Oh, it's a blood thinner, right?
Yeah, it's a blood thinner. So, but with the practicality of treating people with heparin prophylactically for DVT, unless you're really high risk, that's a little impractical. Aspirin in this situation was probably little or no benefit, so it was probably very similar to doing nothing, and that also makes sense. Aspirin is not the best medication if you want to try to treat someone prophylactically for DVT.
What though is there's a comparison when people have the aspirin regimen, but they're with the little ones, the little tiny ones.
Yeah.
And that is
baby aspirin.
Sometimes people forget that they take them. They don't say when they're getting to their doc, "Oh yeah, I take aspirin every day."
Yeah, aspirin often people don't really think of it as a drug, but it is. Yeah, and you should tell your doctor for sure. Interestingly, in this particular study, of the passengers who developed DVT, 85% of them were not on the aisle seat. So
they're not getting up and moving around the cabin because the big guy next to you is snoring and you can't get past him. Yeah.
Exactly. So that again, I think just goes to the immobility issue. But medication. Should we treat people with some form of blood thinner? For prophylaxis during flights? Well, no, that probably is kind of on the fringe. But although I must say that I do remember not too long ago being in line waiting to get on a plane, and a husband and wife were behind me. I could hear them talking, and one said to the other, "Did you bring the medication?" And I immediately thought they were, bringing sleeping pills or Ambien or something so that they could sleep. And as it turns out, it was a blood thinner, and it sounded to me like neither one of them were on blood thinners, but somehow they brought a blood thinner. And they were taking that. So, but I wouldn't recommend that. I wouldn't recommend that without consultation with your physician. Why? Because
what your doc doesn't know might hurt you, it will hurt you.
Yeah,
you got to tell the doc everything.
Yeah. Now, am I saying that it may not? Am I saying that it's not appropriate in some situations? No, it may very well be appropriate in some situations if somebody is very high risk, and if they're going to be traveling for a considerable amount of time. Then, some full therapeutic blood thinner may be appropriate. So. When is it safe to travel relative to surgery? I think that's another thing that we get asked about, because surgery, no matter what kind of surgery you have, it can put you into that, again, a physiologic state where you are hypercoagulable. So, for most major surgical procedures, I think most people would say that you should wait 10 to 14 days before you travel.
That's really interesting.
Yeah.
And those of you that are listening, veinclinicsofhawaii.com, I just throw that in every time. But for those of you that are listening to this, that should be part of your planning.
Mm-hmm.
I mean, if you're going to have, say, a hip replacement, and don't get on a plane the next week.
Right, right. Now, for the kind of stuff that we do, we're intervening on the veins, and the veins is where DVT happens. Mm-hmm. So DVT is a risk of the procedures that we do. Now, in most people who are young, healthy, relatively young, healthy, mobile, active, et cetera, the risk of DVT is very, very low. And typically, the people that we see DVT happen to, post-surgical from the types of procedures that we do are usually the elderly, the people who don't get around very much, and also, and more specifically, those people who are hypercoagulable for one reason or another. Usually we, the people that we do see that have kind of a major problem, and there's only been a handful of those, but often they've turned out to be people who were positive for a genetic, thrombophilia, and often they didn't know about it, and that's kind of how it came to light.
Well, if you're an impulsive person, you don't listen to reason. But I would think that anybody listening to us today might think, oh, hey, I just got to rethink travel plans, just to eliminate or minimize risk.
For sure. So typically what we tell people is 2 weeks. I don't know if there's general consensus, but that's what we tell people. And then the other question is, because of the fact that when you travel, you are kind of in a hypercoagulable state just by virtue of going through the travel. When should you, let's say you're traveling. Let's say you're going on vacation. Let's say you're coming back, back to home after a 6 or 8 hour flight. Yeah. Should you go into the hospital and have surgery the next day?
Probably not.
Probably not. No. And probably the 2 week rule would probably apply there too, because again, physiologically you are hypercoagulable, and you're going to be hypercoagulable for some short period of time. Nonetheless, you are hypercoagulable, and you should be sensitive to that, and insert that into your plans.
Yeah, and one quickie, kind of semi-related to this, and that is when you are being treated, when you have, say, you come in for your annual ultrasound, you find a lot of stuff. What do you do to determine how much surgery or how much can be done to one person at one time? Because obviously, if somebody hasn't been to you for a long time and they got a lot of issues, you can't fix them all in one day.
No, we can't. But we can get a lot. We can get a fair bit done.
I know I've had a lot done
over a short period of time. But we tend to split things up just for the comfort of the patient, for the difference in the procedural things that we're doing, and because of the medication that we're giving the patient, et cetera. But it's over a short period of time we can get quite a bit done.
Yeah, and I'm hoping that the takeaway from today, gang, that though you've been listening, it was really travel, and I think this guy that we talked about was a great example, because almost everybody listening has some of those things.
For sure.
Maybe not all of them, but that's pretty important.
Yeah.
And I just want to remind you from time to time, gang, that you can go to the website, veinclinicsofhawaii.com, and see an awful lot of this, including some podcast stuff and some good video. And I think that maybe it really matters, Doc, when people have an attitude of, hey, wait a minute, I've been putting up with some of these symptoms for a long time. What's it going to take to get used to it? And you do this every day. I mean, it doesn't take anything.
And also with respect to the website, not only is there a bunch of information there, but if for those of you who want to ask us a question,
of course, there
is a link that where you see. Mike, your picture and mine together in the studio.
We look rather smart, I think.
And you click on that, and that'll get you to a place where you can leave us a question. Please do, because we love to answer questions. and then also email here at the studio.
Now, with all the things you've heard today, gang, don't feel like you are afraid to travel, because quite the opposite is true, especially if you travel, you do your plans right, you get things done, and you put them in a line, you'll feel a lot better about it. And inevitably, I think, Doc, you'll have a better time.
Oh, yeah.
If you're not worried about stuff, you can have a better time traveling.
Yeah. We're, I'm not trying to scare anybody. Yeah. I mean, I guess after listening to all this, people are going to be going, "Oh boy, should I do it? Should I ever go on a plane again?"
Yeah, but there's something about that needs to be said, and that is, almost all of us, particularly as most of us are aging in place, and we want to travel. You got that bucket list. You want to go here. You want to go there. You can do it all, but you just got to use, common sense and plan wisely. And you've obviously done that by listening to today's show. Tell other people and come back again and see us next week. In the meantime, for more information from Dr. Juleff and the team, go to veinclinicsofhawaii.com. That's veinclinicsofhawaii.com. See you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.
Let me be straight with you. This is a radio commercial for 3 Small Business Insurance. The policy has no fine print. It's clear what's covered. So while you can't see the following scene, just know that this pet store is protected by 3.
Joe, did you leave the snake tank open?
Look, I don't want to point fingers, but yes.
It's biting me! Sorry, sir. I'm calling my lawyer.
They're going to need some help with this mess. Luckily, they have 3. No fine print, just exceptional coverage. 3 is a product of Berkshire Hathaway Direct Insurance Company. 3. No nonsense, just common sense.